old female posted for electroconvulsive therapy. My concern is it is administered in NORA, sir. Mostly remote areas. Modified ECT means is use of anesthesia and muscle relaxants. Administration of ECT. ECT is a elective procedure. Electric current is applied to transcutaneously to the brain via 2 electrodes. It is usually administered bilaterally. Electrodes are placed over the temporal lobes, but it may be given in unilateral also to the non-dominant hemisphere to decrease the risk of cognitive effects. It requires 6 to 10 treatments twice a week. EEG monitoring is mandatory. Initially localized seizures, which becomes a generalized tonic-clonic seizures within 5 to 10 seconds. The seizure should ideally last for more than 15 seconds, but not less than 120 seconds. If it is more than 120 seconds, it is called prolonged seizures. We should terminate the seizure by using pharmacological methods. Indications are acute life-threatening depression, drug-resistant depression, acute catatonia, and mania. Contraindications are there is no absolute contraindications. Relative contraindications are myocardial infarction within 3 months, cerebral vascular accidents within 3 months, and increased ICP and aneurysms, unstable major fracture, pheochromocytoma, and deep vein thrombosis. If any cochlear implants or brain implants, should discuss with neurology team, but it can be safely administered with permanent pacemakers. Physiological effects of physiological response to ECT for central nervous system. There is increased intracranial pressure, increased regional cerebral blood flow, and cerebral oxygen consumption and glucose utilization. It increased blood-brain barrier permeability. It is used to treat status epilepticus as an anticonvulsant, and post-operative period, post-procedure period, there may be a headache, confusion, transient memory loss. Cardiovascular system, it is biphasic response. Initial brief parasympathetic response lasts for 10 to 15 seconds. It will cause brady, hypotension, and asystole even. Then sustained sympathetic response peaking at 3 to 5 minutes associated with release of catecholamines. It will increase heart rate for 20% and increase BP for 30 to 40%. It increase myocardial oxygen consumption. Even in the normal heart, it will lead to ventricular dysfunction after 6 hours after surgeries procedure. Other effects are increased intragastric pressure, intraocular pressure, nausea, myalgia, and damage to the dentures and oral cavity. Pre-op assessment. ECT is usually performed in the remote area. So ECT should be administered by experienced anesthesiologist. Anesthetic assessment should be carried by the attending psychiatrist ward. A detailed history and physical examination, airway examination, and dentition like any caries tooth or any loose tooth should be mentioned, and treatment history should be carried thoroughly. Presence of any ischemic heart disease, severe valvular disease, uncontrolled hypertension should be carried out. Coming to investigations, routine investigations like CBC, RFT, electrolytes, ECG, chest X-ray. And if patient is on lithium, we have to check pregnancy testing, sickle cell trait, and coagulation profile, especially INR. If patient is taking lithium, has narrow lithium has narrow therapeutic index, so it will trigger nephrogenic diabetes insipidus. Ideally, it should stop before 24 hours of surgery. If patient is taking SSRIs, it will lead serotonin syndrome and SIADH. If patient is taking tricyclic antidepressant and monoamine oxidase inhibitors, it will cause hypertensive crisis. So we have to stop these two drugs 2 weeks prior to surgery. Intraoperatively, we have to obtain informed consent, and patients should be adequately fostered. Aspiration prophylaxis should be given. Sedative pre-medication should be avoided, and pre-oxygenated with 100% oxygen for 3 to 5 minutes. Our aim is to provide short duration of unconsciousness and adequate muscle relaxants. The return to consciousness should be rapid. Full orientation is desirable. Induction agent, there are multiple options like propofol, etomirate, and thiopentone. Either we should choose one, sir. Propofol, IV propofol is the dose 0.75 to 2 mg per kg. Etomirate is 0.15 to 0.3 mg per kg. Thiopentone is 1.5 to 2.5 mg per kg. Ideal is etomirate, sir. we should titrate the dose and according to the patient weight. And alfentanil 10 to 20 mics per kg or remifentanil 1 mics per kg can be used along with induction agent to foster the effect. Muscle relaxants, depolarizing muscle relaxant steroids, suxamethonium 0.15 to 0.5 mg to 1.5 mg per kg. Non-depolarizing muscle relaxant like a short-acting mivacurium 0.2 mg per kg body weight. If the muscle pains means non-opioid analgesic like paracetamol should be given. Anticholinergic drugs, glycopyrrolate can be used to minimize the parasympathetic stimulation because first the biphasic response first is hypotension and bradycardia should attenuate by using glycopyrrolate. We have to give we also give atropine also this indication, but it will cross the blood-brain barrier. For sympathetic stimulation can be attenuated by using beta blockers like esmolol 1 to 2 mg per kg or labetalol 0.05 to 0.4 mg per kg. Airway management, airway and breathing should be supported and only once anesthesia is achieved. A bite block should be inserted prior to treatment to prevent tongue bite. Post-operative management, patient is shifted to recovery room to monitor for consciousness, oxygen saturation and heart rate and BP, sir. That's all, sir.
Okay, but only thing your suxamethonium dose, you said 0.5 to 1.5.
Yes, sir.
1.5 will completely paralyze and make the patient apneic. You want
Yes,
to preserve the spontaneous ventilation or not?
Yes, sir. Spontaneous ventilation.
You have to preserve. So the dose should be not exceeding 0.5 all the time. Okay, it is only to attenuate the intensity of clonic convulsions, tonic and clonic convulsions. Muscle activity should be somewhat reduced, but it should not be totally paralyzed. It is called subparalytic dose. Okay, so that 1.5 will give almost a totally paralyzed patient with you can even intubate that patient. Okay, so here we are not going to intubate. So that is the small thing you have to correct in your answer. Otherwise, this question we have discussed in the theory discussion also recently. We asked one of the questions is the question on ECT management. So almost